I am Dr. Roy. I am a professor of emergency medicine and also the head of the thrombosis and anticoagulant unit at the University Hospital of Angers in France. It is my pleasure to share with you the results of our study, HOME-PA. I think that home treatment of low-risk patients with acute pulmonary embolism will become the standard of care. However, current evidence is mainly based on cohort studies using different sets of eligibility criteria. Therefore, controversy persists about triaging strategy for home treatment of PE patients. So HOME-PA was an upper-level randomized trial with blinded adjudication of endpoints that included near 2,000 of patients with acute PA in 26 hospitals from France, Belgium, the Netherlands, and Switzerland. Our aim was to compare two triaging tools recommended by international guidelines for home treatment of PA, the Hestia rule and the simplified pulmonary embolism severity index, sPESI. Original purpose of the two triaging rules were divergent. The Hestia rule is a checklist of medical or psychosocial conditions precluding home treatment. Conversely, the sPESI is a mortality risk assessment score, and patients with a score of 0 points have a low risk of all-cause death at day 30. The safety of the triaging strategy based on the Hestia rule may be non-inferior to the sPESI strategy and may lead to a higher rate of patients treated at home. However, the two strategies had never been prospectively compared head-to-head. That was the aim of our study. In the AD of participating centers, non-intensive PE patients were assessed for inclusion within the 24 hours following the diagnosis of PE. Randomized patients qualified for home treatment if all criteria of the Hestia rule were negative, or in the other arm, if the sPESI was 0 points. They qualified otherwise for in-hospital treatment. As per protocol, the physician charge could overrule this qualification in case of major medical or social reasons, or when the patient refused the recommendation. But in all centers, a dedicated team conducted the follow-up of patients and offered a telephone service in case of suspected complications. Our main finding can be summarized in this figure, but it needs some explanation. I'll start by the end, because that was our main judgment outcome. The overall rate of adverse events at 30 days, meaning recurrent VTE, major bleeding, and all-cause death, was 3.8% in the Hestia arm and 3.6% in the sPESI arm, confirming the non-inferiority of the safety of the Hestia rule versus sPESI. We will now see in further details how patients were selected for home treatment in each arm. At the first step, a lower proportion of patients were qualified for home treatment with the Hestia rule than with the sPESI. However, among patients qualified for home treatment, the physician in charge overruled the qualification and considered hospitalization less often with the sPESI rule than with the Hestia rule than with the sPESI. As a result, and contrary to our hypothesis, there was no significant difference in the rate of patients treated at home between the two strategies. 38% with the Hestia rule and 37% with sPESI. Importantly, during the 30 days of follow-up, we observed a similar and very low rate of adverse events in patients treated at home. No patient suffered from fatal PE or recurrent non-fatal PE in either arm. In conclusion, the Hestia rule was non-inferior to sPESI with respect to the composite outcome at 30 days, and both strategies can be used for triaging normotensive PE patients for home treatment. With either triaging tool, at least 1/3 of patients can be treated at home with a low rate of complications. Our findings had high-level evidence to current guidelines supporting home treatment with either the Hestia rule or the sPESI. Both strategies led to home treatment with safety of more than 1/3 of normotensive PE patients. So widespread implementation of either Hestia or sPESI could therefore result in considerable cost savings, as more than 80% of PE patients are currently hospitalized in several European countries and in the United States. One important feature of our study is that prior to study initiation, all participating hospitals have set up a specific patient pathway to organize home treatment. In our view, such an organization should optimally be in place before home treatment is implemented. Important question. The beginning of the COVID pandemic corresponds to the end of the trial follow-up, and many of the members of the home study group were then involved in COVID patients management. The main consequence was an important delay in data tracking and statistical analysis. And we have to do important work in a rush to be on time for the ESC Congress.